Hi guys, so for today's video, we're gonna carry on with the cardiovascular system examination. So as far as I can remember, we've done everything up to the palpation of the heart. So we just need to carry on with the rest of the sequence. So we need to do percussion and then we need to do auscultation. So for percussion, percussion has very limited use in the cardiovascular system examination. We can use palpation to estimate the cardiac size, and percussion has very limited correlation to the cardiac borders. So in this sense, we don't really use percussion when we're examining the heart. So we just move on to auscultation. So the first thing that we need to know for auscultation is we need to know how we can best use our stethoscope. So there's two parts, as we all know. There's the diaphragm and then there's the bell. So the diaphragm is better for picking up high-pitched sounds, like the sounds of your S1, S2, mitral regurg, aortic regurg. The bell is better for picking up low-pitched sounds. So these are like the sounds of your S3, S4, and even mitral stenosis. So the second thing that we need to know for auscultation are the auscultation points themselves. So where do we actually auscultate? So if you watch my other videos, I kept saying this. So I use the mnemonic, all physicians earn too much. So A, all physicians, is for the aortic valve area. So that's the second intercostal space at the right parasternal border. And then here we have the pulmonic valve area. So that's the second intercostal space, left parasternal border. And then the third intercostal space, parasternal border, we have the Erb's point. And then after that, at the fourth intercostal space, left parasternal border, we have the tricuspid valve area. And then the fifth intercostal space, midclavicular left side, is the apex of the heart. This is the mitral valve area, where we usually find the apical impulse, which corresponds to the point of maximal impulse. The next thing that we need to know is the pattern of auscultation. So there's really no hard and strict rules on this. You could either start from the apex and move to the base, or you could start from the base moving down to the apex. So if you start from the apex, you start from the fifth intercostal space, midclavicular left side, where the mitral valve area is, and then slowly inch out till you get to the base. Or you could do it the other way around. Start from the aortic valve area, then the pulmonic valve area, then inch down until you get to the mitral valve area. It may be necessary for you to take smaller increments to inch your stethoscope out in smaller increments if that's going to allow you to hear the sounds better. But again, there's no hard or fast rules. You could start either from the apex or from the base. When auscultating the chest, we need to know where exactly we are in the cardiac cycle. Are we in systole or are we in diastole? So we do this by auscultating the chest and palpating the right carotid artery at the same time, like in the lower third portion of the neck. So we know that S1 falls just before the carotid upstroke and S2 follows the carotid upstroke. And we also know that systole is between S1 and S2, and diastole is between S2 and S1. So knowing all of this information, we would be able to exactly pinpoint where we are in the cardiac cycle when we listen to the heart as we palpate the carotid artery. Also, if we listen at the base of the heart, the S2 sound will be a lot louder than the S1, and we may hear the S2 split with respiration. If we listen at the apex, the S1 sound is going to be louder than the S2 sound. During chest auscultation, what we actually do is we place our stethoscope over those important auscultation points to listen for the normal heart sounds, any additional heart sounds, or any abnormal heart sounds or murmurs. I think at this point, I want to go over the different types of murmurs first before I tell you guys the different steps we can take to help us identify these murmurs. So the way that I like to learn, or I like to teach about these murmurs, is grouping them based on where they occur in the cardiac cycle. So we have systole and we have diastole. So systole is between S1 and S2, and diastole is between S2 and S1. So we have systolic murmurs. And actually, we could further divide this into early systolic murmurs, mid-systolic murmurs, and hollow systolic murmurs. So obviously, early systolic murmurs happen just after S1 because they're early in systole, and mid-systolic murmur happen between S1 and S2. And then hollow systolic murmurs occur throughout the duration of systole, so from S1 to S2. And then we have the diastolic murmurs, which happen during S2, so from S2 to S1. And then we have continuous murmurs. So continuous murmurs, they happen throughout the whole of the cardiac cycle. So from S1 to S2 to the next S1. So let's first start by describing the early systolic murmurs. So as I said earlier, early systolic murmurs, they start just after S1. And there's actually a few of these. So we have aortic stenosis, pulmonic stenosis, hypertrophic obstructive cardiomyopathy, and even coarctation of the aorta. But in this video, I'm just gonna focus on the main ones. So I'm gonna discuss aortic stenosis, pulmonic stenosis, and hypertrophic obstructive cardiomyopathy. So let's first start with aortic stenosis. So I'm gonna describe aortic stenosis, but all of the principles and concepts that I'm describing also apply to pulmonic stenosis. Just imagine it happening on the right side of the heart. And this is because pulmonic stenosis is a lot rare compared to aortic stenosis. So I'm just gonna focus on aortic stenosis, but keep that in mind that everything that I'm describing also applies to pulmonic stenosis, but it just happens on the other side of the heart, okay? Okay. So in aortic stenosis, what do we have? So in aortic stenosis, we have a stenotic valve, a stenotic aortic valve. So that means that our valve is narrowed, it's fibrous, it's calcified, very rigid, doesn't want to move, and it's non-pliable. So when the left ventricle contracts to push blood out into the aorta, what happens is that the valve snaps open because it doesn't really want to move. It's very rigid. So it just snaps open. It's not like a smooth opening like normal. So when it snaps open, we can actually hear that snapping open as an audible systolic ejection click. So it's so this is called the early systolic ejection click that is characteristic of aortic stenosis. And this is then followed by a crescendo, decrescendo murmur. And this is because at the beginning, obviously, when the valve snaps open, lots of volume of blood rushes from the left ventricle into the aorta. And over time, as the left ventricle empties with blood, the volume decreases, creating that characteristic uprise and downrise. And again, we hear this as a crescendo, decrescendo murmur, which means that at the early stage, it grows louder and louder, and then it grows softer and softer. So just to summarize, aortic stenosis is an early systolic ejection click followed by a crescendo, decrescendo murmur. Okay, I'm saying early, but I'm going to explain later that the click may occur a lot later in systole. I just don't want to confuse you guys. So again, characteristics of aortic stenosis is an early systolic ejection click followed by a crescendo, decrescendo murmur. This is the same with pulmonic stenosis. But pulmonic stenosis is best heard at the pulmonic valve area, so that's the second intercostal space, left parasternal border. Whereas aortic stenosis is best heard at the aortic valve area, so the second intercostal space, right parasternal border. Also with aortic stenosis, the murmur radiates up to the carotids, whereas with pulmonic stenosis, we don't get that radiation. I just want to quickly explain the disease progression in aortic stenosis and the changes in the sounds that we're going to be hearing. So in mild aortic stenosis, the murmur peaks earlier in systole. But as the disease progresses, the murmur peaks a lot later in systole. Also, the intensity of the murmur typically increases as the disease progresses. But when the patient starts to develop heart failure and reduce cardiac output, then the murmur becomes softer and like less loud and more faint. Therefore, the intensity of the murmur in severe AS is not a very good indicator of the disease severity. We may also hear an S4 sound. So an S4 sound is often heard in aortic stenosis because of the concentric left ventricular hypertrophy that develops in severe AS. Also, we may see the paradoxical splitting of the S2 sound. So normally, physiologically speaking, the splitting of S2 means that the pulmonic valve closes later than the aortic valve. But in aortic stenosis, the closing of the aortic valve is delayed due to the increase in time that it needs for the left ventricle to complete left ventricular systole. And as the disease progresses, so as aortic stenosis becomes worse and worse, that S2 sound actually becomes softer until it actually diminishes and disappears. So when we can't hear the S2 sound anymore, then we can conclude that this is a very severe AS. Finally, I promise this is my last additional point for aortic stenosis. So oftentimes when we auscultate the apex of the heart of patients with aortic stenosis, we may hear a murmur that sounds like a hollow systolic murmur that kind of mimics the murmur that we hear in mitral regurg. So this happens due to the radiation of the aortic stenosis murmur to the apex of the heart, rather than a coexistent mitral regurg. So this finding is called Gallavardin dissociation. Moving on to the next type of early systolic murmur that we may hear is the hypertrophic obstructive cardiomyopathy. So in hypertrophic obstructive cardiomyopathy, what happens is the septum is asymmetrically hypertrophied towards the left side, towards the left ventricle. If you imagine, it kind of bows out into the left ventricle. So there's the septum, and it's hypertrophied towards the left ventricle like this. So what that does, because it's hypertrophied to the left ventricle, it narrows the left ventricular outflow tract. So when the left ventricle tries to squeeze blood to the aorta, what happens is that blood rushes and gushes through that narrowed left ventricular outflow tract. So this gushing of that blood through that narrowed outflow tract actually creates a murmur. So it creates a crescendo decrescendo murmur because at the beginning, there's lots of blood in that left ventricle that goes out to the aorta through that narrowed outflow tract, and over time, as it empties blood to the aorta, then the volume becomes less and less, and therefore the velocity of blood flow becomes less and less, and therefore the intensity of the murmur becomes less and less. So we see that characteristic uprise and downrise again, which we hear as a crescendo decrescendo murmur. So just to summarize, hypertrophic obstructive cardiomyopathy, we hear a systolic crescendo decrescendo murmur. There's no systolic ejection click like aortic stenosis. And hypertrophic obstructive cardiomyopathy, the murmur is best heard at the Erb's point. So the Erb's point is at the third intercostal space, left parasternal border. Just to quickly mention the coarctation of the aorta. So this is also an early systolic murmur. So I'm not going to go into so much detail about it. I just want to tell you guys what you're going to hear. So in coarctation of the aorta, we also hear a systolic ejection click. We also hear a crescendo decrescendo murmur, but the murmur is best heard at the left posterior hemithorax. Moving on to mid-systolic murmurs. So there's only one in particular that we need to know. So we need to know mitral valve prolapse. So mitral valve prolapse can actually progress to a full-blown mitral regurgitation. And mitral valve prolapse can be due to many different reasons. More commonly is due to connective tissue disorders like Marfan syndrome. So in mitral valve prolapse, what happens is that the mitral valve leaflets are weak and super floppy. And the chordae tendineae that are supposed to hold and anchor these valves into the papillary muscles are also very, very weak. So what happens is when the left ventricle contracts to push blood to the aorta, some of the blood gets pushed back into the valve, which is super floppy. So instead of those valves sealing tightly, they bow back into the left atrium. And when they bow back into the left atrium, that creates an audible sound again. So we hear that as a mid-ejection click. So this mid-ejection click, as it bows back, it creates a space now for the blood to rush back, to regurgitate back to the left atrium from the left ventricle. And we hear that as a systolic regurgitation murmur. So in summary, what happens in mitral valve prolapse is we hear a mid-systolic ejection click followed by a systolic regurgitation murmur. And this is best heard at the apex of the heart. So the fifth intercostal space mid-clavicular at the left side of the heart. And this murmur may potentially radiate to the axilla. The last type of systolic murmurs that we need to know about are the hollow systolic murmurs. So hollow systolic murmurs, they occur throughout the whole of systole. So that's from S1 to S2 throughout that whole systolic period. So there's three main ones that we need to know. So we need to know mitral regurgitation, tricuspid regurgitation, and VSD, so ventricular septal defects. So let's start with discussing mitral regurgitation. And the concepts I'm going to describe would also apply to tricuspid regurg, but just imagine it happening on the other side of the heart, on the right side of the heart, okay? So in mitral regurg, what we have is we have very incompetent mitral valves. So what that means is that when the left ventricle contracts to push blood into the aorta, some of the blood would flow back into the left atrium because the mitral valves, they don't close. They're incompetent. They don't shut at all. So that leaves that gap for the blood to flow back, to regurgitate back to the left atrium. So we hear this as a systolic blowing regurgitation murmur, okay? So to summarize, mitral regurg we hear as a hollow systolic blowing regurgitation murmur. We hear this best at the mitral valve area, so the fifth intercostal space mid-clavicular left-hand side, and this radiates to the axilla. In tricuspid regurg, obviously we hear it best at the tricuspid area, so the fourth intercostal space, parasternal border. And in tricuspid regurg, that doesn't radiate to the axilla, but it's the same sound. So it's gonna be a hollow systolic blowing type regurgitation murmur. The last type of hollow systolic murmur that we need to know about is VSD. So VSD is ventricular septal defect. So what happens in VSD is that we have a hole in the septal wall that separates the left ventricle and the right ventricle. So what happens is when the left ventricle contracts to push blood into the aorta, some of the blood gets pushed into the right ventricle through that septal hole. The intensity of the murmur actually increases with the decreasing diameter of that VSD. So the smaller the diameter of the VSD, the smaller the diameter of that septal hole, the more intense the murmur gets. And we hear this as a hollow systolic harsh murmur, in contrast with the murmur that we see or we hear in mitral regurg and tricuspid regurg, which are blowing type. The ones in VSD are harsh hollow systolic murmurs. VSD murmurs are best heard at the fourth intercostal space parasternal border, and these don't radiate into the axilla. Moving on to the diastolic murmurs. So we have four that we need to know about. So we have aortic regurgitation, pulmonic regurgitation, mitral stenosis, and tricuspid stenosis. So let's first begin with aortic regurgitation. So again, the concepts would apply with pulmonic regurg. Just imagine it happening on the other side of the heart. So in aortic regurgitation, what we have are incompetent leaky aortic valves. So when the left ventricle contracts to push blood to the aorta, some of that blood falls back into the left ventricle because the aortic valve is incompetent, so they don't shut. So at the beginning, because of the high volume of blood flowing back, there's a higher volume, which means, higher intensity of the murmur. And then over time, as the left ventricle empties with blood, less and less backflow of blood from the aorta there's less and less backflow of blood from the aorta to the left ventricle. So what we hear in aortic regurgitation is a diastolic blowing regurgitation murmur, and the pattern would be a decrescendo murmur. Okay, so just to summarize again, in aortic regurgitation, we hear a diastolic decrescendo blowing murmur. So aortic regurgitation murmur is best heard at the aortic valve area, so second intercostal space, right parasternal Buddha. And the pulmonic regurgitation murmur, which is similar to this, is best heard at the pulmonic area, which is the second intercostal space, left parasternal Buddha. The next type of diastolic murmur that we need to know about is mitral stenosis. Again, the same concepts would apply with tricuspid stenosis. Just imagine it happening on the right side of the heart. So in mitral stenosis, what we have is a very rigid, very narrow, very non-pliable, doesn't want to move kind of valve. So what happens is that the left atrium has to contract so hard to force that valve to open. So that forcing of the valve to open creates an audible sound that we hear as a diastolic opening snap. So that diastolic opening snap is then followed by a murmur, because at the beginning, the volume of the blood that the atria squeezes through that very rigid valve, the volume is high, so therefore the velocity is high and the intensity of the murmur is high. But over time, throughout the diastole, the volume of that blood becomes less and less as the left atrium empties all of its blood into the left ventricle. So what we get is a diastolic opening snap followed by a decrescendo murmur. Okay, so a diastolic opening snap followed by a decrescendo murmur. So in terms of quality, this is actually a decrescendo rumbling murmur. It's a decrescendo rumble. So the murmur of mitral stenosis is best heard at the apex, and that's the fifth intercostal space, mid-clavicular left side. The similar murmur of tricuspid regurgitation, tricuspid stenosis is best heard at the tricuspid valve area, which is the fourth intercostal space, parasternal Buddha. So continuous murmurs we hear throughout the whole of the cardiac cycle. So from S1 to S2 to the next S1. So there's only one in particular that we need to know. So we have a PDA. So that's patent ductus arteriosus. So in PDA, what happens is that there is a connection between the atria and the pulmonary arteries even after birth. Usually after birth, this hole closes, but in this case, it didn't. So this is the concept I want to explain. So wherever you are in the cardiac cycle, the pressure in the aorta is always going to be higher than the pressure in the pulmonary arteries. So this means that as long as there is blood in the aorta, there's going to be blood that's going to be shunted to the pulmonary arteries. So this constant shunting of blood from the aorta to the pulmonary arteries causes a constant murmur that we hear as a continuous machine-like murmur. So this is best heard interestingly, at the left inferior infraclavicular region, so just below the left clavicle. So that's probably going to be easy to remember because that's very different from the rest. So those are the characteristics of a patent ductus arteriosus. So now let's briefly talk about some of the maneuvers that we can make the patient do to accentuate or to intensify some of these murmurs that we hear, to help us distinguish them from other murmurs that are with similar sounds or similar like patterns. So firstly, we can ask the patient to inspire. So during inspiration, obviously the thoracic cavity expands, therefore there's a decrease in intrathoracic pressure, and that kind of acts like a vacuum. So the decrease in intrathoracic pressure increases venous return, and therefore increase the filling of the right side of the heart. This increases the intensity of all right-sided murmurs, including tricuspid regurg, tricuspid stenosis. During expiration, the opposite is true. So we have a decrease in the chest cavity. So that increases intrathoracic pressure. The increase in intrathoracic pressure during expiration actually squeezes the pulmonary vessels. So that means that the left-sided filling increases. So this means that the intensity of the murmurs originating in the left side of the heart would increase in intensity. So these includes the murmurs of mitral regurg, mitral stenosis, aortic regurg, and aortic stenosis. The third type of maneuver that we could ask the patient to do is to lean forwards. So leaning forwards, what this does, it brings the aortic valve and the aorta slightly closer to the chest wall. So we would hear an increase in intensity of any murmurs originating in those regions. So we would hear an increase in the intensity of aortic regurgitation, aortic stenosis, even coarctation of the aorta, and in hypertrophic obstructive cardiomyopathy as well. Another maneuver we can ask the patient to do is to roll into the left lateral decubitus position. So in this position, what happens is that the apex area, so the mitral valve area and the apex of the heart, comes closer to the chest wall. So we would hear an increase in intensity in any murmurs originating in those regions. So we would hear an increased intensity in mitral stenosis, mitral regurg, and mitral valve prolapse. I'm not sure why the video cut earlier, so I have to redo the last few bits of this video. So apologies about that. So I think we stopped when we were talking about some of the maneuvers that we can do. So I think the bit where I talked about inspiration, expiration, and getting the patient to roll to the left lateral decubitus position, as well as getting the patient to lean forwards, were all recorded. So let's pick up from that. Another maneuver that we can ask the patient to do is some squats. Also, passive leg raises would achieve the same effect actually. So with squatting, what happens is that the veins in the legs, they get squeezed, and therefore more blood gets pushed back into the heart. With passive leg raises, if you raise someone's leg when they're lying supine, what that does is it drains the blood from the veins in the legs. It drains back up to the heart. So it's kind of the same idea. So both of these, what they do is they increase venous return. So with the increased venous return, we increase the preload. With the increase in preload, we increase the stroke volume. So when we increase the stroke volume, that means that all that forward flow of the blood through the stenotic lesions would increase, and all the backward flow of the blood through those regurgitant lesions would also increase. So this means actually that we will increase the intensity of all murmurs, okay? Apart from hypertrophic obstructive cardiomyopathy and mitral valve prolapse. I'll explain what happens in mitral valve prolapse in a bit. So with hypertrophic obstructive cardiomyopathy, the increase in stroke volume generated by squatting and the passive leg raise, what that does, so increased stroke volume means there's more blood that's going to be left inside the left ventricle. So that means there's an increase in left ventricular and diastolic volume. And that means that the left ventricle is going to be a bit more stretched. So in hypertrophic obstructive cardiomyopathy, that increase in blood volume would push out that obstruction a little bit more. So it would how can I explain this? It would push out the obstruction a bit more. It would relieve that obstruction. It would increase the diameter of that left ventricular outflow tract. So the increase in diameter means a decrease in the turbulence of the flow of blood, and therefore the decrease in the intensity of the murmur. Right, so let me just explain that because I don't think I was very clear. So with squatting and passive leg raise, it will increase the intensity of all murmurs apart from hypertrophic obstructive cardiomyopathy, because in hypertrophic obstructive cardiomyopathy, the increase in stroke volume means that there's an increase in left ventricular and diastolic volume, meaning that more blood would push that obstruction out of the way, widening that left ventricular outflow tract, meaning that there's going to be less turbulent blood flow in there, therefore decreasing the intensity of the murmur. Okay, and with mitral valve prolapse, the increase in stroke volume means that there's again an increase in left ventricular and diastolic volume, which means that it would take a longer time for that ventricle to push all of that blood out, and therefore the closing of the mitral valve would be a bit more delayed. Okay, so this means that in mitral valve prolapse, the click would happen a bit later in systole, and the murmur would then be shorter because the click happens later. Okay, so to summarize, with squatting and passive leg raise, okay, it will increase the intensity of all murmurs apart from hypertrophic obstructive cardiomyopathy. And with mitral valve prolapse, what it does, it makes the click, the systolic ejection click occur a lot later in systole, and it makes the murmur shorter. The last maneuver we can ask the patient to do is a Valsalva maneuver. Actually, standing would achieve the same effect, but I think Valsalva is more commonly used. Sorry, just something in my eye. Okay, so Valsalva maneuver, it's basically a forceful expiration against a closed glottis. So it's like you're bearing down. Okay, so you're trying to push air out while your glottis is closed. So what this does is it increases intrathoracic pressure because you're bearing down. So if you increase the intrathoracic pressure, it's going to be difficult for the blood to come back to the chest, to come back to the heart. So increased intrathoracic pressure means you're going to decrease your venous return. Decreased venous return means decreased preload, and decreased preload means decreased stroke volume. Okay, and if you decrease stroke volume, you decrease blood flow. So you decrease the forward flow of blood through the stenotic valves, and you decrease the backflow of blood through the regurgitant valves. So this means that you would decrease the intensity of all murmurs apart from, you've guessed it, hypertrophic obstructive cardiomyopathy. Okay, so everything decreases in intensity apart from hypertrophic obstructive cardiomyopathy when someone does a Valsalva maneuver or when they're standing up. And the reason for this is because in hypertrophic obstructive cardiomyopathy, the decrease in venous return, the decrease in preload, the decrease in stroke volume means decrease in left ventricular and diastolic volume. So there's not going to be much blood that would stretch that obstruction out. So the left ventricular outflow tract would actually be smaller in this case because we don't have as much blood as normal. And the smaller the diameter, or the narrower that left ventricular outflow tract is, the more turbulent the blood flow, and therefore the more intense the murmur gets. And also there's another exception, mitral valve prolapse. Okay, so for mitral valve prolapse, the decrease in venous return, the decrease in preload, the decrease in stroke volume means the decrease in left ventricular and diastolic volume. So that means that the left ventricle is not going to take as much time to pump all of that blood out, and therefore the mitral valve would close a lot sooner. So that means that the systolic ejection click that we hear in mitral valve prolapse will now occur earlier in systole. Okay, And if that click occurs earlier in systole, that means that the murmur that we will hear will be a lot longer. So the murmur would be longer, okay? So just to summarize, sorry, losing my voice. With Valsalva Maneuver and standing as well, it's the same thing. Well, it achieves the same effect. What happens is we are gonna decrease the intensity of all murmurs apart from hypertrophic obstructive cardiomyopathy, because that murmur would get louder, okay, or more intense. And with mitral valve prolapse, what happens is the systolic ejection click occurs a lot earlier in systole, and the murmur that we hear following that ejection click will be a lot longer. So let's quickly talk about the grading of the murmur before I move on to the tips that are going to help us identify the murmur when we hear them in our exams. So grading of the murmur, we grade it from 1 to 6. So grade 1 means that the murmur is very faint, and the listener has to really tune in to hear the murmur. Grade 2 means that the murmur is quiet, but it can easily be heard, when we place a stethoscope on the patient's chest. Grade 3, the murmur is moderately loud. Grade 4, the murmur is loud with a palpable thrill. Grade 5, the murmur is very loud. There's a palpable thrill, and the murmur can be heard even when the stethoscope is barely touching the chest. So it's partially off the chest. Grade 6 is the worst. So grade 6, the murmur is very loud. There's a palpable thrill, but also the murmur can be heard even when the stethoscope is completely off the chest. So that's the worst. Okay, so grade 3 and above is usually pathological. For the final part of this video, I want to go over some of the tips that are gonna help us in identifying the murmur when we hear it in a patient, or when we hear these kind of murmurs during the exam. So firstly, we need to identify or establish the timing. So where does this murmur occur in the cardiac cycle? Does it occur in systole, which is between S1 and S2? Or does it occur in diastole, between S2 and S1? Or does it occur throughout the entire cardiac cycle, from S1 to S2 to the next S1? Right, so if the murmur occurs in systole, so if it's a systolic murmur, if it occurs early in systole, so an early systolic murmur, that gives us a clue. So this can be aortic stenosis, this can be pulmonic stenosis, this can be coarctation of the aorta, or this can be a hypertrophic obstructive cardiomyopathy. If it occurs like mid-systole, then this can be a mitral valve prolapse. If it occurs throughout the whole of systole, if it's a hollow systolic murmur, this can be mitral regurg and tricuspid regurg. And if it occurs kind of just throughout the entire cardiac cycle, then this may be a PDA, or a patent ductus arteriosus. The next thing we need to establish is the location. So where is this murmur heard the loudest? Is it heard in the apex or the mitral valve region the loudest? Then if so, then maybe this is a mitral stenosis or a mitral regurgitation or a mitral valve prolapse. Also, we need to ask ourselves, does it radiate anywhere? So we know that aortic stenosis radiates up to the carotids, and mitral regurgitation radiates to the axilla. The third thing is the shape of the murmur. So we really need to listen carefully to identify the shape of the murmur. So is the murmur a decrescendo murmur, which means that it grows softer? Is it a crescendo murmur, which means that it grows louder? Or is it a hollow systolic or a plateau murmur? Is it just the same throughout? Or is it a crescendo decrescendo murmur, which means that at the beginning it grows louder and louder, and then it grows softer and softer towards the end. Next one is the pitch. So is it high pitch or low pitch? So high pitch murmurs include aortic stenosis, aortic regurgitation, mitral regurgitation. Some of the low pitch murmurs include mitral stenosis. The next thing is the quality of the murmur. So is it a blowing type of murmur? So blowing murmurs are usually regurgitation murmurs. So that includes mitral regurg and tricuspid regurg. Is it a like a machine-like murmur. So that's characteristic of a PDA, a patent ductus arteriosus. Is it a rumbling murmur? So if it's a rumbling murmur, so if it's a diastolic opening snap followed by a diastolic decrescendo rumble, then that is indicative of mitral stenosis or even tricuspid stenosis. The next one is the intensity of the murmurs. So because all of these murmurs are pathological, they would be around about grade 3 or even higher, depending on the severity of the disease. And the final one that you can assess to help you identify the murmur is the special maneuvers that we can ask the patient to do to intensify some of these murmurs. So for instance, if you ask the patient to roll on the left lateral decubitus position, then you would intensify the murmurs of mitral stenosis and mitral regurgitation. If you ask the patient to lean forwards, bringing the aortic valve region and the aorta closer to the chest wall, you would intensify the murmur of aortic regurgitation and aortic stenosis.